Okay, we're going to start a review of Psych Unit 4. Remember that this test will be on Monday, which will be November the 1st, and this will cover chapters 13, 14, 15, and 16 in your VitaBeck textbook. Chapter 13 dealt with anxiety and the anxiety disorders. The first slide that you see here has to do with obsessive compulsive disorder, which is one type of anxiety disorder. Chapter 14 dealt with schizophrenia. 15 dealt with the mood disorders, which would be depression and bipolar. And then chapter 16, we talked about the different types of personality disorders. So that's what the test Monday will include. Now with chapter 13, remember to focus there on anxiety. There were a couple of things that I pointed out to you, specifically the levels of anxiety: mild, moderate, severe, and panic. The person at mild anxiety, that's kind of a butterfly type sensation. With mild anxiety, the person can actually learn better and they can focus. That can be a helpful thing for solving problems. Moderate anxiety, the person can still be redirected, but they're starting to have more trouble to concentrate, but they can be redirected. But you'll see more automatisms, which, remember, automatisms would be like tapping their foot, biting their fingernails, twirling their hair, something like that. Severe anxiety, the person can no longer be redirected. They're restless. They have trouble thinking. You see vital sign changes. And then we said the worst thing with panic, or the top level of anxiety, is that they're totally in fight or flight. They either fight, flight, or freeze. They can bolt out in front of traffic. We said they're a safety risk, and at that time you should not leave them alone. They may not be able to respond verbally or communicate in a way that you can understand, but you shouldn't leave them because you really don't know what they're going to do. They're unpredictable at that time. Anytime you're working with anxious clients, you want to try to get them to a non-stimulating environment. So you want to try to remove them from any place that's feeding the anxiety. You want to be calm. If you get anxious, then of course, that's going to just raise their anxiety level. So you want to speak to them with a calm voice and give them short, simple information like, come here, sit down. Just basic 2 or 3 word sentences. We also talked about different kinds of anxiety disorders, and that's where OCD comes in, where you see here on the slide. OCD is one form, but some of the others that we mentioned, we talked about agoraphobia, which is the fear of being in a place where you can't escape, like a crowded ball game or something like that. We talked about panic disorders and panic attacks. We also talked about specific phobias to certain things, social phobia, and generalized anxiety disorder. Remember, with generalized anxiety disorder, they have to have the anxiety almost every single day for 6 months or more to be considered generalized anxiety disorder. We said that's the most common psychiatric diagnosis. It's more common in women, young women who are single, divorced, separated, and we said it's due to financial issues a lot of times. We also talked about PTSD, or post-traumatic stress disorder, in this chapter. So look back at that and what meets the criteria. That person is usually hypervigilant, they're hyper alert, they have sleep disturbances, flashbacks, nightmares. So review some of those criteria for what's considered PTSD. Now, as far as OCD is concerned, or obsessive compulsive disorder, it basically has 2 parts. It has the obsessive part and the compulsive part. The obsessive part are the thoughts, whereas the compulsions are the actual behaviors. So, for example, this person's thought is, I'm so bad I made a mistake. The compulsion, or the action, is, I better wash my hands. The compulsion has a purpose, and I hope you remember that the purpose of the compulsion is to try to relieve their anxiety. So the person here is washing their hands because they feel like that somehow washes away their mistake. So if they feel bad and feel like they've made a mistake, they need to wash. They're trying to, through this behavior, relieve that anxiety. Remember also that we talked about with OCD, we talked about how to treat that. We said that you wouldn't necessarily make them stop doing whatever ritual it is. So for this person right here, we probably wouldn't tell them that they can't wash their hands, but we would restrict it somehow. So we might tell them that they have to be done washing their hands by 9 o'clock and be sitting in group therapy. Or we might tell them that they have, by a certain time they have to be finished, or they can wash their hands as many times as they want to, as long as they make it to all the sessions that they're supposed to be at during therapy, or something like that. We as long as they can continue to do the things we want them to do, we don't tell them that they cannot engage in their compulsion. Because if they were unable to engage in the compulsion, that would raise their anxiety level. So we know that the compulsion for them is serving the purpose to lower their anxiety level. But it doesn't work, or else they wouldn't keep needing to do it over and over again. We talked about the fact that the person knows who has OCD, they know that the obsessive thought is not true. So this person knows that they're really not a bad person when they say, I'm so bad. They really know that they're not a bad person, but they can't make that thought get out of their head. We talked about people who feel like there are germs everywhere and everything's contaminated. They know at some level that that this is an abnormal thought. They realize that they have a problem. They do have insight into this, but they can't make it stop. They feel powerless. They realize they're being irrational, but they just can't fix it. They can't stop. We want to make sure that they can carry out their roles in society. Can they carry out their responsibilities? That's one way to know or to judge how they're doing. Can they carry out their role maybe as a mother or as a student or as an employee? Can they carry out their roles, or is this impairing their daily life? Okay. The next chapter, chapter 14, had to do with the mood. Chapter 14 has to do with schizophrenia. Chapter 15 has to do with the mood disorders. And of the two mood disorders, we talked mostly about depression and bipolar disorder, which is depression with mania mixed in. Look at all of the assessment for depression, or all the features here. We always want to assess the suicide potential, and we talked a lot in class about assessing that. For example, you want to know if they have a plan to commit suicide. Then you assess the lethality of that plan. In other words, do they have access to something to use to commit suicide? Look at people who are at risk, adolescents and the elderly. We said that men are usually successful, whereas women try more. Look for a recent change, a recent loss, death in the family. Substance abuse. For older people, a lot of times it's a chronic illness or a painful illness like cancer. Previous suicide attempts, and we said within the last 2 years, that should be a red flag. Look at all these criteria. Psychotic, neurotic. Has the person been treated previously with either meds or electroconvulsive therapies? We said that people who are suicidal usually would be diagnosed with clinical depression. Depression is the leading cause of suicide. Look for suicidal preoccupation. Teenagers especially will talk about it a lot. They'll talk about death. They may be fascinated by death, be looking at sites on the internet related to death. Just have a negative view of the world, themselves, their future. They will say things like, things are never going to get better. My whole life's ruined. So they tend to speak really negatively about everything, and they don't think things are going to get better. We talked about this loss of interest in pleasurable activities or fun things like hobbies or going places. We said that was called anhedonia. They can be agitated or have psychomotor retardation. We did talk about that. The people who are agitated are more likely to be fighting or anxious or yelling, whereas the people with psychomotor retardation would sleep all the time, be the kind of person that would have trouble getting out of bed in the morning. Fatigue, they tend to drop weight because they don't have an appetite. Sleep disturbances, decreased libido, they care about intercourse. Some things that we do, let's look all the way up here at safety precautions. We remove the harmful objects, so things like belts, knives, matches, medicines, sheets from the bed even sometimes, because they could hang themselves with those, shoelaces out of their shoes. There's just a lot of things we take away. Close observation of that person, and that means one-to-one observation, so a staff member with the patient all the time. And we do use those written no suicide contracts that we talked about in class. An assessment of depression, we talked about in class the Beck Depression Scale, which was an objective test for depression because it gave the person a numeric score. But here's some other things that you would just want to remember to think about or ask them about. Sleep disturbances, and it can either be sleeping too much, like all they want to do is sleep, or it can be that they have psychomotor agitation and they're too anxious to sleep. So it can be either way. Decreased interest in pleasurable activities, and that includes intercourse. They just, they're not, nothing makes them happy anymore. Guilty feelings, they feel guilty about past behaviors, or feel guilty about that they're not a good enough parent, or they're not a good enough daughter, or they're not a good enough wife, whatever it is. E is for decreased energy, and then you've got CAPS over here on the bottom right, and that, think about decreased concentration. So they're hard to teach, because when you're trying to teach them, they're going to have a hard time paying attention to what you're saying. Appetite changes, either high or low. Some people eat when they're depressed. Most people, more commonly, people lose their appetite and lose weight. Changes in psychomotor function, usually it's decreased. Some people become agitated. And then suicidal ideations or suicidal thoughts. Suicide precautions, think about anything a person could use to harm themselves. So window glass. We even have on psychiatric units, a lot of times we have mirrors and windows that are made out of non-breakable glass. Plastic flatware, they wouldn't have a fork to eat with, or a knife, of course. Phone cords, equipment wouldn't have a power outlet. It wouldn't have an electrical cord that you plug into the power outlet, because they could use that cord. Curtains would be something that we would avoid. Belts, matches, razors. We definitely use the one-to-one observation, and we constantly ask them about suicidal intentions. It's kind of a myth that if you ask somebody if they're suicidal, that'll make them do it. That's totally a myth. That's untrue. We actually do question them very frequently as to how they're feeling and if they are having thoughts about hurting themselves. If you can develop a therapeutic close bond with that patient, then the behavior contract seems to work better. So in other words, before you have them sign one of these suicide contracts, you really need to have a relationship with that person for it to be effective, so that they trust you to have their best interest at heart, that kind of thing. Restraints may be used at times. Remember all the protocols for those. Medications might be used. And we have to monitor visitors. So don't think if the patient's on one-to-one observation and a family member comes to visit, that's not our cue to leave that other person in charge of watching the patient. It's always the staff person's job to watch the patient if they're on one-to-one observation. We also, in Chapter 15, talked about mood disorders, and bipolar was one of the other ones that we talked about. It's everything that we've said about depression, the hopelessness, decreased anhedonia, decrease in pleasurable activities, negative views, loss of appetite, decreased libido. It's all those same things mixed in with a person who cycles over to mania, where they have an elevated, expansive mood. Some people are very, very happy and like they're hyper. Other people are more irritable, agitated, and ready to fight. Pressured speech, we said, where they talk fast and loud, don't hardly take a breath when they're talking. They might lose weight because their appetite decreases. They might have grandiose delusions and feel like they can run miles, or they may in their mind think that they can make good investment decisions. They might move their money and put it in crazy investments. They're real hyperactive. They don't need to sleep. So you need to find ways, if this is an inpatient, to handle all that energy they have. They can get out and walk, but any other activities that you can have them do where they keep moving and stay busy. This person needs something to do. They need a job. Sometimes we let them fold clothes. We let them dance. They need to do something where they can burn off some of that energy. And we did talk about finger foods as being a way to keep them from losing weight. Okay? Back up to Chapter 14, and Chapter 14 deals with schizophrenia. And there were all different types of schizophrenia that we talked about. We talked about the paranoid type, where the person's going to have some eating and sleeping disturbances because they think that we're going to hurt them either through poisoning their food or we're going to harm them while they're sleeping. We also talked about the disorganized type, where that person is just going to have more of an unkempt appearance and have a hard time carrying out any kind of activity. They're going to have the clothes that are inappropriate to the season. They're not going to be able to perform basic care for themselves. And then the catatonic type was another type we talked about, where the person had more movement changes, psychomotor disturbances. They might have echopraxia, where they repeat everything that you do, or they might have waxy flexibility, where they are almost catatonic, but you can go over and bend their limbs and straighten them out. We talked about undifferentiated type of schizophrenia, where it was schizophrenia mixed in with other changes in their affect or behavior, so it can be like schizophrenia with depression mixed in. And residual type, where the person's had a psychotic episode, but they're not currently psychotic. That could almost be like the person who has postpartum psychosis. With schizophrenia, this person, probably of all the disorders, has the hardest time functioning in society because they're out of touch with reality. They don't relate to other people. They tend to really stand out as being different. They're kind of in a fantasy world. They just can do some really odd things. They have no social awareness, so they don't have any idea of what's appropriate social behavior and what's not. They have hallucinations, delusions, illusions, but they don't have very much insight into how different that they are. They don't realize how much they stand out. Even though they stand out to us and we can obviously tell who they are, they don't realize that they're so different. And again, this is just a reminder of what these words mean. Hallucinations is when you have a sensory stimulus or a sensory impression without an external stimulus. So in other words, this person sees this monster even though there's nothing there. So it's like the person who hears voices but there's nobody talking. Or they see spiders crawling on the wall and there's nothing on the wall. Whereas an illusion with an eye, this is when the person misinterprets a real stimulus. So they see this guy who's just holding his hand up waving at him, they see that he is angry and holding a knife. So they misinterpret a real stimulus. I think I gave the example in class one time about how maybe the wallpaper is a patterned wallpaper. Maybe it like has stripes or checks in the wallpaper and the person misinterprets that as bugs crawling on the wall. That's an illusion. A delusion down here at the bottom is a fixed false belief. So that could be the delusion. I gave the example in class of a lady that thought she had a relationship with Tom Brokaw, and she believes it. That some of those are harmless, like this woman believing that she's Cleopatra. That's not harming anybody, but where a delusion can be harmful is when they have the delusion that we're all out to get them. Paranoid kind of delusions to the point that they won't eat food in the hospital or they won't take their medicine because they think we're poisoning them. So some delusions we don't treat if they're not harmful, but if their delusion is causing a safety risk to themselves or others, then we have to treat it. These symptoms, these three symptoms, hallucinations, illusions, and delusions, these are considered psychotic symptoms, so we treat these symptoms with antipsychotic drugs, and you want to review all about those. I've just thrown in some slides here that deal with some of the medications to remind you to review medicines. The medicines are found in these individual chapters, so they're found in 13, 14, 15, and 16. Those chapters contain medications. But then you want to also go back to Chapter 2 and look at the tables where they talk about the antipsychotic classes and side effects. Those are going to be really important. Wellbutrin, remember bupropion, this is a drug that is an antidepressant. It can also be given in the drug name of Zyban, and that's a smoking cessation aid. But the two drugs are the same thing. They're both bupropion, and when used as an antidepressant, it will help with mild to moderate depression. But you don't want to mix it with tricyclics or MAOIs. Remember, when you start mixing these drugs together, you can have toxic reactions. Thorazine is one of the conventional antipsychotics. So this should trigger your memory and maybe send you back to Chapter 2 to look at all of those different antipsychotics and their side effects. The conventional ones had the most side effects. So they had the extrapyramidal side effects, tardive dyskinesia, where you had the facial movements, abnormal movements of the mouth. Also, big side effects included these anticholinergic side effects, where you had blurred vision, hypotension, dizziness, lack of sweating, constipation, dry mouth, nasal congestion. These are These are anticholinergic side effects. So look for those. Look at what all of these mean. Extrapyramidal system effects, those have to do with movement. Akathisias, where they just can't be still. They have purposeless movement, it's called. Parkinson symptoms, that's where they take on Parkinson gait changes, where they shuffle, they lack arm swing. They may pill roll with their fingers. So look back at the side effects of those drugs. Haldol is another conventional antipsychotic that has a lot of side effects. So look back at those. We talked about acute dystonic reactions right here, where they can have torticollis of their neck. They can actually require PRN doses of Benadryl or Cogentin to relieve muscle spasms from taking conventional antipsychotics. This AIMS scale is mentioned in your textbook. It's the Abnormal Involuntary Movement Scale. This scale actually is used by psychiatric nurses and psychiatrists to rate whether or not somebody is developing extrapyramidal side effects as a result of taking antipsychotic drugs. So this will actually rate the amount of abnormal movements that a person has. And notice that the first category up here has to do with facial and oral movements. And so if they had these are signs of tardive dyskinesia. So you could actually grade the person, and this is called the AIMS scale, or the Abnormal Involuntary Movement Scale. And remember that these abnormal movements are coming from a side effect of antipsychotic drugs, especially the conventional group. Okay, the MAOI inhibitors, this is a class of antidepressants, and the big thing with those were that if they take those with tyramine foods, they're going to have a hypertensive crisis. And tyramine foods are things like cheeses, wines, and preserved meats. We call these aged cheeses and aged meats because they're meats that have been packed in preservatives. So think of lunch meat, hot dogs, smoked sausage, things that have a preservative to it. The meat's already been cooked, and basically you just warm it up or you eat it as it is, like salami, or I guess Spam. Spam would qualify too. The person, if they're taking Nardil or Parnate or Marplan, when they eat these foods, they'll have extreme hypertension. SSRIs are things like Paxil, Zoloft, and Prozac. Celexa is also in this class. These are really good for mild to moderate depression. They won't work very well for more moderate to severe depression. They have fewer side effects than the other antidepressants, but they still have side effects. So things like weight gain, sexual dysfunction can still occur with these. Besides just giving them for depression, remember that we use SSRIs for anxiety disorder and for OCD. Tricyclics, Elavil, Doxepin, Pamelor, Tofranil, these we said are more for moderate depression rather than just mild depression. They will have some anticholinergic side effects to dry everything up, so pay attention to these side effects over here. Also remember that it doesn't take much of an overdose to be lethal with tricyclics, so watch out for the suicidal patient to take several of these and commit suicide. Okay. Also, I would like for you to look back at the personality disorders. I gave you a handout in class to kind of give you an example of a person with each of the personality disorders. Remember that these disorders occur in clusters. Cluster A is the more odd or eccentric person. They're not really thought to be harmful as much as they're just weird. They do weird things, like the paranoid person could be a safety risk. If they think you're out to get them, they might try to get you first. But the schizoid person is the person who is just very dry, has almost no social relationships with other people, no friends, not close with their family, they're not married, no children, but they're happy like that. They're happy to be totally absorbed in their work and not have much socialization. Schizotypal, we said, is the person that's just going to probably stay in their house and might have odd delusions, like they have odd beliefs about things, maybe have odd or unusual religious beliefs, but tend not to be bothered by the fact that they're sort of a recluse or they're sort of, they keep to themselves. Cluster B people are the dramatic, emotional, or erratic folks. That's where antisocial falls, borderline, histrionic, and narcissistic. So you want to review the difference there. And then cluster C is the more anxious or fearful, the people that avoid taking any kind of risk. Avoidant personality disorder, dependent, and obsessive compulsive fall under there. They tend to be more of the worrier type. And we said that personality disorders, of all the mental health disorders, they're the hardest to treat because your personality is sort of ingrained by about the age of 2 to 3. And these people tend to be the lowest on insight. They're the least likely to think that they have a problem. They tend to think that everybody else has the problem. So just realize that even though you'll see medicines listed as being treatments for personality disorders, a lot of times you don't see a lot of results from them. And the only time that we get these people in usually is when they're involuntarily committed, because they're not ever going to come in seeking treatment on their own because they don't think that they have a problem. This really concludes the review for chapters 13, 14, 15, and 16. The test is on Monday. Please let me know if you have any questions.